So I have a first question to Dr. Gurki. What is the value of doing an intra-op kind of a gram staining or a frozen section, and how often do you do it in your practice?
To be honest, we never do it. Why? Because it's not very reliable, first. And second, it's very difficult to find a pathologist who is really experienced in the judgment of a frozen section regarding infection or periprosthetic joint infection. So it gives us usually no additional information. That's the reason why we never use frozen section or grafts.
Anybody in the panel?
In continuation to that, suppose in a primary surgery, if you find some suspicious tissue of infection, so do you change your decision?
Yeah, if I have the suspicion in a primary implantation,
Yeah.
I stop the implantation, I just take samples, tissue samples, close the wound and wait.
Okay, send it for culture and all.
Yeah, send it for culture and anything.
Yeah. Yeah.
Thorsten, lot of patients get systemic side effects with antibiotics like oral ulcers and nausea, etc. My question to you, however, is: are there any studies which have investigated the influence of local antibiotics through local Hickman catheter versus systemic antibiotics?
Yeah, there are older studies from 25 years ago or even 30 years ago where they looked after the load of the body by giving local antibiotics in the bone cement. And then they measured the elution rates and the concentrations, and to be honest, no general side effects if you respect the cutoffs. So if you respect the maximum of the maximum doses that you can give as an antibiotic. So for example, we have heard it, you can give in a cement space of 4 to 8, maximum 8 gram antibiotic.
No, my question is with local Hickman's catheter. Local catheter.
Local catheter. I have no experience with local catheter. We don't use it.
That is, I think, one of the ways of local antibiotic delivery. So either you put a Hickman catheter or put stimulant or whatever. So systemic and local antibiotics, I think they are complementary to each other. You cannot replace the Hickman catheter only antibiotic compared to the, replace with the systemic antibiotics. Let's go to microphone 3, please.
Hello sir, I just wanted to know, when do we label it as a culture negative PGI?
Okay, what is the definition of culture negative PGI?
Yeah, the definition is that you in a proven PGI you cannot detect the germ, the causative germ. So that's the definition of the culture negative one. It's easy. So it's a proven PGI. All the parameters are elevated, they are all over the cutoff, and it's obviously an infection, but you cannot really detect the bacteria.
So is it inadequate sampling or erroneous transport leads
That we discussed, how to improve your culture yields to stop antibiotics 2 weeks before surgery, within 2 hours it
So
should
do
be
we skip pre-op antibiotic also? Pre-incision we give antibiotic half an hour before. In those cases, holiday free, like antibiotic holiday free period, like do we give the antibiotic
so if
before
the pre-operative antibiotics has a bearing on the intraoperative culture samples?
Yeah, there's still a debate. So shall we start with antibiotics intraoperatively after taking out the last sample?
Right.
This is what we did for decades now. So this is what we did. But there is a debate at the moment in literature. It seems to be, it doesn't matter. You can start with the perioperative antibiotic prophylaxis or antibiotic therapy and take out the samples later. So the literature at the moment says it does not influence. But we are very old-fashioned. We still do it. We just start with our antibiotic therapy after taking out the last sample.
So microphone 4.
So can I ask another last question?
Just please, there are so many people are waiting. Now microphone 4, please.
Yeah, so you laid a lot of emphasis on debridement. Just wanted to know what are your broad steps of debridement at your institute, first. Second, does the antibiotic free period does not also tells us whether our CRP and ESR you said it is not relevant nowadays, the CRP is falling. So the falling trend, and then we give an antibiotic free period, and then we see whether the CRP is not rising again. Does that not gives us a sense that okay, there is not an active infection at least?
Yeah, of
So
course.
I think Prof has already told that they are not giving any antibiotic free period now.
No,
They
I
are
just
doing
want-
immediately.
Just wanted to
surgery.
have,
Yeah, so first of all, about the debridement.
yeah.
How do you perform the debridement? And I mentioned to you, it's like tumor surgery, as radical as possible. And debridement is a manner of experience. It has so much to do with experience. Our surgeons who are allowed to perform these kind of surgeries are very, very well trained. They do about 80 to 100 septic exchanges a year. So they are much better than me. I do less in the meantime, much less. So when I do a septic exchange, I take one of them with me in the OR just to judge about the tissue. And I ask him, do you think it's infected or not? And if he says, it looks suspicious, I cut it out. So this is regarding the debridement. It needs experience.
So it's basically a clinical sense of judgment that you have.
Let's go to microphone
Exactly.
one. Yeah, please.
So-
So please short questions, not very big questions. We are
No, we are
running short
discussing-
of time.
yeah.
Yeah, and
Mic
the other
one.
was with if you stop the antibiotics, the wound looks good, the CRP is not elevating, then you can go straight for the reimplantation. But even it's not only the laboratory parameters, it's also the clinical signs.
clinical
So if the
judgment.
wound looks good, that's much more important than the laboratory parameters, because CRP can stay over the normal value for a year. But the symptoms, the wound, how the wound looks, is it oothing, is it red, is it warm? This is much more important than looking after the CRP.
Yeah,
My
microphone
question
one.
to all the panelists, if you have acute PGI 1 year post TKR and aspirations are negative, will you do a DARE or you will wait or you do a 2-stage? What is your protocol?
Acute means in our
Like within a week you have diagnosed it's a frank infection, the aspirations are purulent but they are negative.
yeah. So it depends on the timing. If the infection occurs within the first 3
Yeah,
weeks
that's what I-
after implantation, we try to save the implant by performing a DARE.
No, sir, it's 1 year post-op. and
1
that-
year post-op,
Yeah.
no, never.
So you do a 2-stage.
I mentioned it already. Onset of the clinical symptom is very, very difficult to judge. So if I have an implant which is 1 year inside and develops an infection, we go for a 1-stage or 2-stage exchange.
Even if the joint is stable, you will do a 1-stage or 2-stage.
Microphone two, please.
Depending on the knowledge of the germ. If we find the germ, 1-stage, if not 2-stage.
Thank you.
Thurston, I reviewed 2 papers from Germany on the outcome of infected revisions. One from Endoclinic, which was your group, and you claimed that the 1-stage is a gold standard. And you used 90% of the hinge knees as an implant for this, meaning you may be extremely radical. The other paper was from Hanover Medical School, which is a really big place again. They claim that in their center, they have higher risk of infection in 1-stage, so they don't recommend 1-stage revision. And they have used maybe 20% of implant as the hinge knee, while 80%, 85% are the constrained design knee. So basically it boils down to how much radical you want to go. And if you want to go that radical, then what you say is quite right. The question is in India, do all we go that radical and remove everything, no matter what it comes, including ligaments? We normally don't. That's the reason.
That's a very good. First of all, Hanover is a well-known trauma center in Europe, but not a well-known center for joint replacements, to be honest. They do about 25 septic exchanges a year. We do about 500. So it's, okay, but we have to discuss it. Do we have to be as radical as we are?
No, what I'm comparing is Hanover could be like Indian centers.
Yeah,
And you are
but you have seen the results.
Garka from.
You have seen the results. If the debridement is not really radical, you get another infection again. So we do believe really in the radicality, and this is there's common sense all over the world. What kind of implant you use? We are radical with the hinge knees. You can use, in some cases, CCK or VVC knee. You can use, even in some cases, depends on the infection. You can even use a PS design in some.
No, I understand. What I'm trying is the radicalness of your debridement. Are we all doing it here?
Setup, what,
If you are not doing that radical implant, then the message that the one stage revision is gold standard should not go from this dais.
Yeah, if you are not as radical as we, one stage exchange doesn't make a sense. But to be honest, my friend, two stage as well not. So septic revision is radicality, independently for what you are doing, one stage or two stage.
That I agree.
That's the basics. It's a basic principle is radicality. You cannot operate a tumor and say, okay, I do it not so radical, probably it works. And I have a smaller surgery, or here in India in some institutions they cannot. In tumors it's clear. In tumor you would be absolutely clear and say, be radical as possible. But infection is the same.
That is the reason maybe we want to give antibiotic-free period where we are not very sure how radical we have been, and then wait and see.
Microphone one, please. Yeah.
I just wanted to share an experience with the panel and the house. So we do around 2,500 TKRs per annum, and for a decade, our infection rate was a little under 1%. Then came COVID, and we started using N95 masks. And that alone, that factor alone has brought it down to nearly 0.2, 0.3%. So I felt that this thing was not discussed, the theatre protocol, and something as simple as an N95 mask actually nearly eliminated infections for us.
Maybe you can use hood system also.
But
thank you for your suggestion. Yeah, Rajiv.
Two short questions to Dr. Thurston. One is that biofire, use of biofire. Biofire does show us a lot of false positives. So is it worth using in our practice?
Oh no, biofire is not too bad. They are not showing many false positives. They are much better. They are much better. It's a great thing. So, but the problem with biofire is that they do not, they cannot detect. They are not able to detect the most common causative germs.
Yeah.
Two germs, and that's a problematic. These, if you cannot find the two main germs, then probably it's limited the use of biofire.
And what is the choice of antibiotic when you are waiting for the culture sensitivity report?
So we are talking about, so if he has the germ, if he has the susceptibility, it's clear for the microbiologist which antibiotic he has to give. If it is not clear, then we talk about calculated antibiotic therapy. It's a calculated one. And I mentioned it, if it is really severe infection, then we start mainly with meropenem or imipenem because it's broad, it's dangerous, as I told you before. And if possible, we try to give rifampicin, but never alone, as we all know. Ideally, but this does not cover really everything. Ideally with the clonidine, oxacillin, fluoxacillin or something. Rifampicin with oxacillin is fantastic, but to cover everything, you should give meropenem or imipenem.
But rifampicin should not give given as a single antibiotic for resistance. Last question, please.
Yeah. My question to Professor Thorsten. So do you recommend to put a stab incision while doing an aspiration? I can see in your video you didn't do it, but is there a chance that you can introduce some skin commensals in a non-infected replace? Putting a stab incision before aspiration?
Yeah, it's, so this is a question that I was answered since 20, 30 years, so I don't know to be, there's no proof that this really reduces or improves the the reliability of our aspiration. So it's some institutions are doing it, a little skin incision, and then to avoid contamination with skin germs, I have no answer. You can do it. You can do it. For the patient, it's not really very comfortable. We don't do it.
I think most of us, we just directly inject. Anyway, thank you, gentlemen. Give a big hand to the panelists for the peri-procedure.